Fatima has now picked up the battle once again to fight for people who are vulnerable in this country, but who might be considered to be in the back of the queue when it comes to COVID-19, the access to the COVID-19 vaccine. Fatima, thank you so much for joining us on the show. Really do appreciate it.
Oh, it's a pleasure, Oliver. It's really great to be on the show.
Fatima, where does your anxiety stem from that vulnerable people, particularly in poor countries, might be considered the least important when it comes to the access and distribution of the COVID-19 vaccine, whichever vaccine we get access to?
Yeah, I think that's a great question, and the anxiety really, emerges from the experience that we had with HIV/AIDS, and there were many people who I was really fortunate to work alongside. From clinicians and scientists and doctors to activists, including people living with HIV and AIDS. And what we experienced during that time was basically a system where the global south was excluded from immediate access to life-saving interventions in the form of ARVs because of two reasons. One was either the lack of political will or lack of political urgency. And in South Africa in particular, it was worsened or aggravated by HIV/AIDS denialism by the Mbeki administration at the time. But the second main reason and the obstacle to be able to access affordable life-saving interventions was the patents regime that applied to ARVs at the time, and so continues to do so today, which basically in effect meant that because of patent monopolies, it was almost impossible for poorer countries or countries that are regarded as middle income to access large amounts of affordable supplies of ARVs and then to be able to allocate that equitably in the public sector. So the situation we had in South Africa in the late 90s and early 2000s, well before the state actually agreed to provide ARVs in the public sector, was that people who were rich and who were wealthy and who had medical insurance were able to afford very expensive ARVs and able to basically buy their life. And poor people who were mainly, black women in our country were disproportionately affected by HIV and AIDS were unable to. So, what we saw in the early days of the COVID epidemic when it first emerged was similar signs around the nationalism and similar signs around the way in which monopolies can exercise power in relation to many different countries and their public universities and institutions, which basically would preclude you from getting immediate access. And unfortunately, on the last day of 2020, here we are discussing the very issue that we had raised from March already, which was that we're going to have a repeat of the HIV/AIDS crisis in terms of access.
Now, we've already received reports from the Ministry of Health that ICUs across the country are full, that there's very little space for patients, and this would be particularly poor patients finding themselves in remote areas across the country where they often have to travel many, many, many kilometers, sometimes have to walk many kilometers to access a hospital or any such facility. Surely then the question is, should we not focus on access to treatment rather than the COVID vaccine? Because many people, as we currently speak about the vaccine, which has not yet arrived, are not getting that access.
So I think it's a combination. You can't have a healthy nation, you can't address the disparities in our two-tiered healthcare system if you can't get out of this pandemic. And, the indications at the moment is that while we're in a second wave, we potentially could be facing a third wave and a fourth wave in the next 12 to 18 months unless we can get urgent supplies of a vaccine to be able to try and at least mitigate some of the devastating impacts of the pandemic. So I think it's a combination of making sure, especially for people who are older, for people who have comorbidities, not to have the disproportionate impact of COVID also playing out in their lives. So, I think what it also points to is what we raised earlier on in March, which was that COVID was going to expose all of the fault lines of the way in which power works in the world, but particularly in our country. And it's definitely exposing the fault lines of our two-tiered healthcare system. And so there's going to be some hard policy choices for government and for the ruling party to make in the next few years, given what we've seen with COVID and, like you say, the devastation, particularly for communities in remote areas or far-flung areas or in areas where the hospital services have all but collapsed. Whether we'll actually be able to manage to implement national health insurance. And I think that's going to be a key policy decision. The second key policy decision that government's going to have to make, and that's why we're eagerly waiting for them to actually engage with us on this issue and to share this information with the public is how is it going to respond to the power of the pharmaceutical industry and to pharmaceutical companies who at the moment in this pandemic are exercising an extraordinary amount of power. And they exercise their power in multiple ways. One, in terms of deciding which geographies get supplied first, which companies are permitted or not permitted to manufacture a copy of the vaccine. And thirdly, they also determine the pricing. So, once again, we're in a situation where government is being asked, and we're pleading with government to basically assert its authority. Rely on the Constitution, rely on the various pieces of law that we have to be able to declare in this pandemic that the way in which the allocation and the pricing and the supply system is working is actually not in line with our Constitution and is actually not fair or equitable.
Effectively, are you then asking for the supply, the procurement and the supply and distribution of the COVID-19 vaccine to be nationalized? That is to say, not a single private company should have any exclusive decision-making power to determine where the COVID-19 vaccine is going first. So that's to say, Pfizer shouldn't hypothetically decide, oh no, we're going to give this to Discovery Health first, because they're paying more than the government would, and therefore Discovery Health patients who are in private medical health care are prioritized in that instance. Are you asking for that to be done away through some form of nationalization of the procurement, supply and distribution of the vaccine?
So, nationalization is a hard word for people to appreciate and understand, and I'm certainly not asking for that. What we are arguing is that because this is a pandemic, because it's a public health crisis, and there are exceptional circumstances. I mean, basically our country is being devastated, and so many other countries around the world, both rich and both poor. So what we're saying is that you can't have a system in this current climate where you allow parallel procurement and then parallel distribution, because what will happen is a repeat of what we had with ARVs, where people with medical insurance and people with money will have first access to limited supplies. Because remember, there's global shortages, there's scarcity. Our country is going to have to ration. And there is a legal framework that would allow government to say that even if the private sector supports you with financial resources and is able to basically, in inverted commas, get their hands on some limited supplies of vaccines, there needs to be a national allocation framework which is rooted in equity. And it's the argument, basically that a person who's over 75 in the public sector can't be waiting for a vaccine while somebody who's young and healthy and is a member of a prominent medical scheme gets first access to it. So it's not a nationalization. I think it's giving effect to what the Constitution provides in Section 27. It's about government having a reasonable plan that can pass constitutional muster, and they may not be popular, but they have to step in. There are laws that also allow government when supply and demand is basically at risk, and where private pharmaceutical companies can't meet demand. There are mechanisms that government can use to basically compel those companies to share their technology. But one of the greatest risks we're facing in the global side right now is that many of these drug companies, while some of them may be offering a vaccine at a low profit price or no profit price, are not willing to share the technology. And unless the vaccine know-how is shared widely and more openly, then it's going to take many years for the global south basically to catch up to where the wealthier countries are going to be in the next 12 months or so.
Much of government's response so far has to say that we do have the necessary legislation in legislative framework in place in line with our Constitution. And this, of course, is due to a lot of the litigating work that you did in the early 2000s and the late 90s. And if we couple that, for instance, with the popular super money case early on in our democracy that litigated, for instance, with dialysis, access to dialysis, with the Constitutional Court upheld important constitutional rights over there, we do have the necessary framework. All of that brought us to this moment that prioritizes vulnerable people and poor people. But of course, sometimes a lot of the corruption that exists in the system doesn't happen at a legislative level, neither does it happen at a national level. Sometimes it happens at a localized level where clinics, for instance, or workers in clinics and in certain hospitals and in certain government institutions are trying to solicit a bribe, for instance, from vulnerable patients to get this life-saving drug. Are you at all concerned about that happening? And do you think government should proactively, if at all, react to that? And what should that look like?
Yeah, I mean, I think that that's a valid concern. There's certainly, been a decade of what we call state capture and a hollowing out of state institutions. We have a public health system that's very precarious. The first problem linked to the earlier point that we were talking about was that we also have an incomplete net and pricing framework. So one of the concerns that we have is that if the private sector is able to procure vaccines on their own, they may be paying a higher price for the same product while the public sector gets, a public tender price. So that's the first issue. So in relation to corruption and in relation to the inability in some cases and in some provinces of the state to be able to roll out, this is where partnerships do matter. And I think that obviously government is going to have to be honest about its own limitations and ask the different role players in the private sector for assistance in administering a massive national vaccination program. And it's certainly what we're seeing playing out in other countries. Because if you want effective immunity, you're looking at potentially immunizing up to 40 to 50 million people in South Africa, within months. So the logistics and, the requirements of that are quite intense. But first we have to get our hands on a vaccine that is considered safe and effective. In relation to corruption, in relation to the administration of a vaccine, we haven't seen evidence of corruption in relation to the administration of ARVs. I think where you have strong clinical protocols, we have strong clinical regulators, we have healthcare workers who are so honest, who are working so hard. We don't foresee issues around, corruption in the actual administration of the vaccine program. But there's definitely concerns around capacity.
Yeah, and that, of course, is going to be a big conversation going into next year. And, of course, we have to ask the question, can we even afford it? If we buy, for instance, the Oxford vaccine, which comes at cost of about $3.50, we'll at least need about, at minimum, 10 billion rand in South Africa to be able to just procure the two dosages per citizen that we need to be able to vaccinate the entire country. And so all of that will be a big conversation over the next couple of weeks, couple of months. But Fatima Hassan, thank you so much for your time. Really, really do appreciate it. Have a good new year and all the best.